I'm mic'd up, so that'll be fine. Thank you very much, Jeff. Well, thank you for that kind introduction. It's a real pleasure and honor to be here. So my task is to tell you about Tele ICU now and the future. But actually, this has been an interesting journey for me because when I went to Penn, I hadn't really done Tele ICU before. And this has been a journey developed through COVID. But I think what we've ended up is with a platform that is backbones for every single health system for the future. These are my disclosures, but the only important thing is I have no relationship with Epic because a lot of this talk is going to be based on the Epic Tele ICU platform that we've built at Penn. I'm going to talk through what we all know about a traditional Tele ICU and its functionality. Look at how we can build high reliability into the platform. And I think the real difference of what I'm going to show you is we've always had monitoring and our EMR in parallel. And this is the first time the whole thing's ever been integrated in a way that you've got structured governance and two-way actioning within the EMR. And as I say, I think I'll point out in the future that this is the basis can be used not just in the ICU, but across the whole of the health system. So for those that don't know, Penn Medicine, it's a big academic health system based in Philadelphia. We've got 6 main hospitals. One of the terms I'll be using is Penn e-LERT. That's purely what we call our Tele ICU program. It's actually been around for about 25 years and at Penn, and it's a 24/7 bedside support service. So it's an addition to the bedside provider. It's not replacing the bedside provider. But since I've been there, we've grown it from really quite a very small system to basically the biggest academic Tele ICU platform in the country. We've got 450 ICU beds, and we have many other monitored beds because we're now branching out into high-level care. And we've also got portable platforms as well for emergencies and small community hospitals and things. So these are the 7 main hospitals we deal with. So they're big hospitals. I mean, Lancaster General is a standalone hospital in itself with its own cardiac department, as is Chester County. And then we've got the downtown hospitals, and we're also in New Jersey at Princeton. The whole basis of the staffing is we have 4 RNs 24/7. So they have about 100 patients each, which is a lot for an ICU, but you'll see with the platform we've got, they're highly efficient. And they're also a filtering mechanism, as well as the fact that they've done ICU for at least 7 years, all of them, so that they recognize problems. We've introduced a 24/7 APP model, and we've also got 24/7 respiratory therapy, which I'll talk about, which is the first ever in the world. That came through COVID. And then we have nighttime physician support. We don't need that during the day because the teams are on the ground, and as well as a telehealth coordinator. And really, this is what triggered it all. This was Megan's and my life for a year or so, wasn't it, Megan? COVID, it completely disrupted technology. Everyone was willing to grasp new things. HIPAA was sort of parked, wasn't it, for a while, and everyone could use any platform they wanted to deliver patient care. And the opportunity came really because I was out. To give you an idea of what we did. I mean, we even were called on Christmas Eve to support one of the vent facilities in Philadelphia because the whole system had run out of ICU beds, and there were 60 patients with COVID. And we went in with iPad cameras and supported their respiratory therapists. So we effectively stood up a Tele ICU for 60 beds within a few hours and had it centrally linked back to our downtown Rittenhouse, where our core is, where all those people were. But the real opportunity came when we were asked to partner with Epic, because the opportunity was to build our platform within the EMR. And so that's what I'm going to go through. And as I say, this is the first time that everything's been fully integrated. And I'm going to start where we finished because I think it's easier, and then how did we get there? So this is one of my APPs. This is the average sort of dashboard that they'll look at. So if you think we've got unit data. So the top left is a list of patients that you'll be looking after. So the nurses have more, and then obviously higher risk patients get then transferred to an APP or an MD. And you can see, so it's like a watch list with basically cycling, SOFA scores, and then the best practice alarms there. So you can see, and then a patient goes to the top, on the top left, if they fire red. So the whole hospital system is live, and every patient that has a BPA that fires, which is red or orange, will go to the top of the list and get looked at next. The second screen on the top right is a physiological data set for the patient. The reason that is in black is we've actually built this whole thing in something called Epic Hyperspace on Warp Drive. Now, before you all think I'm a Trekkie, yeah, okay, I did enjoy that when I was a kid, but that's just the term that Epic use for basically running almost a parallel EMR, but it doesn't have the functionality. It's purely a graphical interface, and that's why I took the advantage of it, because those of you that know me know that I was a photographer before I went into medicine. I'm a firm believer of graphical interfaces. And Careline, which just got presented by Suba, that's a fantastic graphical interface. We use that a lot at Penn. So I've effectively done a little bit of what she's done, but into the EMR in the Tele ICU. And the whole idea is to stop the clicks and to just see the data and to visualize the delta. So that's really what this is about. So I always remember this, the craziest thing that we had back in the UK is they started to say that we needed to have all anesthesia syringe labels the same color so that you read the label. And I kept saying, well, we're very visual orientated animals, we're color based. So red is good for muscle relaxants because it kills people. And you're color based. So you shouldn't be reading. So that's basically how we've designed this interface, so that everything is just a delta and a color. You don't actually need to know the value. You know that something bad is happening to the patient. And then finally, the bottom left, you've got the classic interface that we've got. That's where the camera system goes in. And then we've got our own other clever dashboards on the right, which I'll show you. This is a game changer. It's a new type of camera. We've partnered with them. And it's so high powered that you can basically see what's written on someone's iPhone in the room. It's two-way, it's Zoom, it's controlled by the downtown Tele ICU people. But the thing is it gives you situational awareness and two-way communication. So our picture goes up on a board so the provider can see us and we can see them. So it's immediately like FaceTiming. But the other great thing we've done with this is stopped working, by the way, sorry, is this can be used to get any single person into the room, anywhere in the world, within seconds. So basically, if you press the e-LERT button on the wall, which every room has, and you say, I want Dr. Mike Scott now, I will get a immediately URL. I'll go on my phone, I press the link, basically up there, that's what comes up on my phone. I accept it, and then I am in the room. You can see me top right there, and then I've got situational awareness. I can control the camera, and we can bring other people in. So I'll say, oh, right, we need a cardiac surgeon in on the call, get them in on. So immediately you've got a path to high-level decision-making, which is one of the failures of delivering high quality and high reliability. So this has been an amazing addition to the system rather than just normal Zoom cameras. You're all aware that most Tele ICUs are all about reactive. So you've got immediate threat to life, trending threat to life. I don't really need to tell you what these issues are in the room here, but we've worked out that 80% of the opportunity is basically at weekends and at nights, and it's no coincidence that's when we've got lower bedside staffing. It's inevitable, isn't it? And also we can talk about monitoring again, can't we, there? But that's another can of worms that we've already discussed. So we support the bedside provider. We can watch the patient for them. as well. We can get all the teams in. We can fire a massive transfusion trigger. We can record video, so it's a learning opportunity. And so this happens a lot, but mainly, nights and weekends. But the real service that we've built up is this proactive service, and it's all about quality bundles, and it's everything from respiratory to sepsis to ICU bundle, and it's become basically a platform for system-wide quality improvement. And it's a continuous opportunity. It's harder, isn't it, with all these quality improvement things to show cause and effect. But if you do the whole bundle of elements, just like when you've got enhanced recovery, it's hard to actually say it's one thing that's doing it. We know that some things are probably a bit more impactful, aren't they, like fluids and blood pressure. But on the whole, you need the whole thing. And this reduces complications and secondary problems downstream as well. This is what I work on when I was in Virginia as sort of perioperative quality lead. How do we fix the space? And these are normally the points of failure. I'm going to start with the bottom one first, really, which is what we call a safe environment, which we've introduced at Penn now. A safe environment, not clinically safe for patients. It's where everyone is free to ask for help without feeling that they're weak or looked on as not knowing their things. So it might be just a nurse. We had one the other day. A nurse said, I don't understand this. I've had to pull 20 ampoules of this drug to give this. And she was sensible enough, she called because the dose had been entered wrongly. And she was sensible enough to think, actually, this isn't right, isn't it? 1 ampoule's normally enough. Why am I pulling 20? So it's at 3 a.m. in the morning, and rather than giving it, she didn't know who to call. She didn't want to challenge the bedside provider, so she called Penn e-LERT. And we said, yes, wrong dose, you're right. So it was a good save. And it's these little catches like that that really help the health system. It's not just about going in there when patients are dying. So we've created a safe environment. So I don't safety net anyone or anything. I just pick up the phone if there's a problem. And then you've got the things like there's failure to follow best practice. So that's, as you can see, that's more proactive management. There's failure to recognize a problem and failure to escalate it appropriately are 2 points of failure. And then lack of governance in any of those above. So I'll show you how we fix this with the platform. And then could you fix this? Because it sort of slides behind for some reason. When you look at costs impact to your health system and using this as a big quality improvement tool, our average cost at Penn is about $17,000 as our median cost. So the actual, once you've got your Tele ICU in place, it's actually not that expensive when you look at the cost of running it every year compared to the number of complications that you save. And we're all aiming, aren't we, in the C-suite for high reliability. But in fact, we're an awfully long way off high reliability in healthcare, aren't we? I mean, we know that. That's why we're all in this room. This paper and editorial in the BMJ really showed that, and this is only 6 months ago, that there's a long way left to go. But the whole principles, and Monty Mythen's in the room with me, and we worked in the UK ERAS implementation, and really that covered everything from quality, safety, length of stay, everything. And this was really how I think we viewed what happens. We send a patient on their pathway, and any pathways, whether it's ERAS, whether it's sepsis, it's just basically lots of mini bundles, isn't it, of best practice. So you're trying to keep the patient on the pathway. However, despite the fact that you do everything correctly, we still have some patients that decompensate and actually then go on to get complications. And we know that from Ghaffari's work that it's not the number of complications that health systems have, it's failure to detect them and to intervene that actually determines your overall quality figures. So the sooner you can actually detect this is happening, the better. So that's what the other thing we've built into the platform. So we utilized the EPIC SOFA scores. This was very challenging because no one would accept the fact that because we didn't have bilirubin, and which is part of the SOFA score, you couldn't have the SOFA score. And I kept saying, well, look, you've got to be realistic. Really, just it's always naught unless you're doing a liver function, because the only reason we do liver function is when we know there's something wrong with the liver. So that took an incredibly length of time to get everyone to agree on that, but we've got that. But you can see here that you've got, this is the clinical deterioration board, 4-hour trends. And then this gives you an idea of what the interface looks like on the right here. And we've got 4 patients parked on high watch. And then we can still use this screen in the middle. It's a widget screen. I'll show you how that works in a minute, because you can just spin the boxes and get whatever you want in them to save your real estate. But building best practice alarms was one of the key things, because I don't like all this noise from alarms. And this was a real opportunity, because we could finally not use the bedside monitor alarms. We could actually build our own alarms, some smart alarms. So this is what we did. So we built a whole load of best practice advisories. They're not simple 1+1 pass-through. They're integrated, and we're making them more and more complex as we've now got live waveforms in. And the other key thing is they're adjustable at a bedside level. So if we've got a cardiac patient, we can just click, all right, cardiac data set for that patient. Well, we might tolerate different, map, for instance. And there's a validation process associated with every BPA, which is basically, is it an artifact? Is it actionable? And if it is actionable, follow the action, and how do you do it? But the first thing we did was we used third-party software, and we actually got rid of 40% of the noise, which has been incredible. And then also we don't fire the alarms audibly. Nothing is audible. If you walk into our unit with 450 ICU beds, there isn't a single sound. There's no alarm beeps, because it's just distracting, it's overwhelming. So we've integrated into the EMR the camera with one click there, and also this is we call it our widget screen. As I say, it's built in Epic Hyperspace. But it's a very elegant way of getting visual information, and it's no clicks. You just move the mouse over, and it will come up with the next level down as you go and do a deeper dive on each system. And then we've got integrated live waveforms, which is the first time ever in the world this has been done. I'll show you how we did that in a minute. But the thing I'm most proud of is actually governance. And that's the thing I learned in the UK, is if you don't have governance in your health system, everything falls apart, from quality to safety, everything. And so I think you're aware in Epic you have to validate alarms. The bedside nurses get overwhelmed with this. But we use unvalidated data. So it just comes through to us. And our data is not just firing on absolute values, it's also on deltas and trends. This one gives you an idea. This is the commonest false alarm pulse oximetry. I think you're all aware of that. We got rid of an awful lot of false alarms in pulse oximetry, but we still have to go in the room. So basically, if you get this up, you just click on the, so it comes up with the patient, pulse oximeter alarm, click on the patient, you click on the camera, within 4 seconds, you're in the room. You can see what's happening with the patient. You can see what else, you've got all their other waveforms. And so you really know what's happening with the patient with its artifact. So you can either click it off, that's artifact, or you're not sure, might be low, you can pause it and come back in 2 minutes and it will come back with a reminder. Or you can escalate it according to what you need. This is a bit more of a meaty one. This is hypotension, so we have a much more defined sort of escalation. But can you see we've actually built in this into the EMR? So no alarm can actually escape. And we have millions and millions of alarms, BPAs, being worked out every day on our patients, of which we action about 900. So that's 900 actionable alarms where we're actually stepping into a room, getting the bedside provider, and just doing, it might be a minor delta, because the SATs are low and they just need a bit more oxygen, or it might be the fact that they've got a tension pneumothorax that's been undiagnosed and the patient's in distress and no one's recognized it. So this is the hypotension one. I can't see, I don't know if you can read that, but you can park it for certain numbers, minutes and things like that. But also it has other support, like, is the patient hemorrhaging? It's got all decision support there built into this, layer upon layer as you go through. So that's the clinical governance. And then it's getting the right person to the bedside is the other governance. Those are the two main points of failure. So for every single unit at Penn, I have created this with my team, which is the clinical interaction model, which is everything. Does the data come in? Does it need escalating? Talk to the bedside nurse, validate it, escalate to the APP. Do we need the MD? Do we need the attending who's at home? And so this is a cardiac one, and you can see everything ends up going to the cardiac attending because that's what he wanted. So anything on that list in the middle, he wants to know about. So you can see that it's very powerful, and it's very different from each of the units, and it depends if we've got a fellow on a unit. If we've got a surgical critical care fellow, it's a very different algorithm to if you've got an APP-led system. And then at the top there, you can see we've got the patient population, what the actual staffing model is, what our staffing model supporting is. So to give you a little bit more flavor of the functionality, now one of the issues I think you're aware with Epic is they don't allow you to really show their product. So I've done some screenshots which have been approved, but I'd love to show you the video of the true functionality of this because it just saves all those clicks. You can just move your cursor over and everything pops up. So I'll show you what happens on the RT service and how we've also improved the workflow. So just to remind you, these are the dashboards. So we've got a proactive, a reactive, and a predictive sort of interface. These are the workstations. So I talked about unit level data on the left, patient level data. You can see there we've got the physiological waveforms in, and then the patient level interaction. So this is the unit data. I've shown you that already, but this is just starting to show you how the alerts come up. So they're color coded. We know whether it's respiratory. We know if it's renal. We know if it's blood pressure. And also on the right here, we've got quality improvements. The top right, those two, that's actually a quality improvement thing that needs to happen. So that's vent orders. So this patient doesn't have any vent orders. So you can see it's not just about treating the patient. It's all about this proactive quality, making sure bad things don't happen. And this is what I'm most proud of. This is I built this with Heather and the team. So this is the widget board. So you just scroll over it and it gives you a deeper dive. So you can see this is everything a respiratory therapist knows to round on every patient. So we have one RT who can round on 450 patients. Because this board, you just click it up. If nothing is in red, you almost go on to the next patient because everything's in order. It's that simple. It's everything from what type of airway they've got in. Are they ready for a spontaneous breathing trial? Do they need a sedation hold? What's happening to their vasopressors and everything? And then if you just move your cursor, you get a deeper dive, and these are the deeper dive. What automatically then drops down as your next sequence. So you can get all the information you need very, very quickly. So you can see fluids down the bottom there, and all types of fluid, whether it's TEN, TPN, fluids, or blood. We've got other integrated applications to achieve this. We have something called an ICU board, which one of our pulmonary critical care attendings has built, Barry Fuchs. It's a very good thing that we ran with in the morning on all the units. And it's basically a nudge board, just to make sure what's happening with the patient, everything from ventilation, SBTs, have they got low stretch ventilation ordered and things, and then other things about mobility. And then we've also used sickbay to get our monitoring waveforms in, and this can be done two ways. You can use it as a unit base with the Epic Monitor, or you can actually bring it in through context-aware linking, which is what we did into the EMR. And it's useful because you can basically put it anywhere. I mean, I can have this all up at home. I can have all the ICUs up at home if I need to, but Not that I do take my homework like that, but I'm just saying you can put it anywhere on anywhere where you've got basically a Cat6 cable. And then this is what it looks like. So again, we're taking all the noise out. So this is our neuro unit. So you can see different color coding and you can configure this all sorts of ways. And finally, to close the loop on quality improvement is always you've got to look at what you're doing, track the data, and give feedback. So the great thing is in this whole system is we've built this whole thing into the EMR so that we've got quality dashboards and something called Penn Diver, so we can track the quality of the whole ICU across the health system and our own performance at the Tele ICU and how long we're using cameras for, how often we're using them. So finally, just to close, everyone thinks, well, could you do a whole ICU remotely, Mike? Well, the answer is yes, and we do. Because we actually have one of the first gift of life centers for organ donation. So we respectfully look after those patients. And because there's no FDA approval needed for anything, we actually partner with Medtronic, and we've got software now where we control all the ventilators remotely. So we admit the patients, we do all the orders, we do all so apart from having an A line and a central line, everything's done remotely with those patients, just with the bedside nurse. And this gives you an idea of what the nurses will see when we go into the room. So we have these big screens. So in summary, this is what we've built. You can see on the bottom left, the patient bedside provider to the traditional interface. And then you go up to the electronic medical record. But what we've done is we've pulled all this physiological data both into basically up to the cloud first and then back into the EMR. But also into the EMR directly through two different ways. But you've got this sort of, it's basically in a control tower model, isn't it? With the bottom right, where you've got your ERN, ERT, EMD, EPP interfacing, but also you can always get, using this two-way visual, audio-visual connection, the highest level decision-making into room for a patient immediately. So we're basically ensuring all patients are treated the same. There's no weak link, so it gives you high reliability. You've got both proactive and reactive detection. And obviously, it means that we intervene earlier, so you get better outcomes, and it leads to quality and efficiency. So really, if you go back to this slide, we've fixed it, because we set our own best practice and follow it. We get early detection, and recognition of life-trending changes. We escalate appropriately, both clinically and the bedside provider, and we've got governance. So nothing escapes, because it can't, because you can't get out of there unless you've actioned. And we've created that safe environment. So really, although I was asked to talk about the future, I think the future is already here. And that's been one of the great things about COVID, I think, is it really accelerated technology. So you can see we've got a fully integrated functional platform. The dashboards create this incredible user interface and speeds, proficiency of rounding, and also you get the data quickly. And we're trying to put this now bedside. That's what we're doing, is we're now building dashboards to use in clinical practice by the bedside. We've got best practice. We've got our best practice advisory. So that's been key, building those. And because we've now got waveforms, we can build even cleverer best practices. And also we can start doing things like AKI prevention, hypotension prediction built in, because you can take risk from the EMR and build it into the physiological genomic. You've got situational awareness, and as you can see, really, our next step, we've already gone into high-level care. And you can see from that last slide, we can even link this into wearables. So it's really a health system fix. And it drives high reliability, efficiency, quality, health equity, value, and safety. So thank you for listening. But it does take a village. So I'd like to acknowledge all these other people as part of my team. Thank you.